Okay, so I'm Carissa Bishop. I use she, her pronouns. I'm the founder and executive director of Access Care Anywhere. I serve on the Medicaid Advisory Council or Committee's Advancing Consumer Experiences Subcommittee. I am a person with lived and living experience and with having Medicaid, OHP specifically. Also as a child, having CHIP health insurance. And so I wanted to bring to your attention the recently published federal register or federal rules ensuring access to Medicaid services final rule that was published on May 10th and will take effect on July 9th, 2024. So these improvements seek to increase transparency and accountability, standardize data and monitoring, and most importantly, create opportunities for states to promote active beneficiary engagement in their Medicaid programs with the goal of improving holistic access to care. So while there's many highlights of the provisions that are listed, and I can provide the link to this, what I'm referencing, I want to go over, there's three that I want to discuss. So one of them is for the Medicaid Advisory Committee and Beneficiary Advisory Council requires, the new rule requires states to establish a Beneficiary Advisory Council comprised of Medicaid beneficiaries, their families, and or caregivers. It establishes a minimum requirements for MAC membership, including a requirement that 25% of the MAC members will be drawn from the BAC, the Beneficiary Advisory Council. And thirdly, it requires states to provide staff to support planning and execution of the MAC and BAC activities. So I want to make the MAC and the public aware that OHA staff member Sarah Witherson notified me in an email earlier this week that despite being a member of the MAC's Advancing Consumer Experiences ACE subcommittee, and I quote, "Since you are not a member of the MAC and your attendance is not there is not required, we will not be able to compensate you for attending MAC meetings going forward. Therefore, this not only undermines the new CMS requirements, but also indicates that my, as well as other Medicaid beneficiaries, their families, and or caregivers, active participation in MAC meetings is not welcome nor valued." And in reference to the state providing staff, I would like to request that the state provide staff to these groups that are people with lived experience of having Medicaid or being a Medicaid beneficiary. I'd also like to share that I feel mistreated by Ms. Witherson, and I have emails to back that up. And it's made me feel very uncomfortable and unwelcomed. I don't know why she has some sort of vendetta against me. I'm only here to advocate for myself and other Medicaid OHP members. And I think it's undermining this federal rule and the MAC overall. And I want to bring it to your all attention. Thank you.
Okay, good morning. Welcome, and I'm Sarah Witherson, she, her. I'm a white woman with graying brown hair and glasses. I lead the staff for the Medicaid Advisory Committee, or the MAC. This is the MAC's public meeting for May 2024 to help fulfill its federal and state mandates to advise both the Oregon Health Authority, or OHA, and the Oregon Department of Human Services, or ODHS, on how to run Oregon's Medicaid program. And so I'm going to share a few logistical announcements before we get started. I'm going to ask that folks mute yourself if you're not speaking, and for people joining by phone, please mute yourself if you're not speaking, and please avoid putting the meeting on hold. If you must leave, it is better to hang up and rejoin the meeting. And MAC members, we ask that you use the raise hand button if you have a comment or a question, and please put, or else please put a note in the chat. So the Medicaid Advisory Committee has built in time for discussion after each presentation. MAC members will speak first, and we'll leave exhausted questions from the MAC members. If there's any time remaining for the agenda item, we will take general questions. We also have left 10 minutes for public comment near the end of the meeting. We have ASL and Spanish language interpretation available for today's meeting. You can pin ASL interpreters video by clicking on the More button next to their name. There's also a button for interpretation, which is where you'll find the Spanish language interpretation at the bottom of your Zoom screens. Now I'm going to hand off to the MAC co-chair, Heather Jeffress, to take us through our meeting.
Thank you, Sarah. Appreciate that. Welcome committee members and members of the public. Let's go ahead and get started with our roll call. Okay.
Yeah, this is Carissa Bishop. It sounds like the meeting is starting after my public comment, so I want to note on the record, in case it's excerpt from this, that Carissa Bishop provided public comment to this meeting.
Absolutely. Thank you. Thank you. Okay. All right. Are we ready to proceed with roll call? All right. First, Dr. Caroline Bennett.
Barrett, and
Barrett,
yes,
sorry.
I'm here. Good
Sorry,
morning.
Caroline.
No problem.
All right. Alweb.
Here.
David Lima.
Here.
Gabe Triplett. Myself, yes, I am here. Hillary Thompson.
Good morning, I am here.
Thank you, Hillary. Jerry Weeks.
Here.
Kelly DeVore.
Here.
Kaya Adams. Okay. Laura McKean.
I'm here.
Lisa Pearson.
Here.
Ronnie St. John.
Here.
Shannon Buck.
I'm here.
Dr. Tony Germain. German,
Good morning,
excuse me.
here.
Tony.
How are you?
And I'm good. How are you? Thank you. And Peter Starkey. I have my reading and then what I know your name is, and the two don't often match. I know. Okay. All right. Well, thank you, everyone. And we do have quorum, I believe. Yes. Okay. All right. You have folks may have noticed a new name on our roll call. David Lima joins us as a newly appointed member of the MAC. Welcome, David. He brings, among other things, professional expertise in both Medicare, Medicaid administration, and lived experience with long-term services and supports. David, would you like to introduce yourself briefly and say a few words about why you were interested in being part of the MAC?
Yeah, thank you. Thank you for having me. I'm glad to be here. I'm honored. I grew up in the healthcare system, so to speak, as I started my career many years ago at Care Oregon, and grew up with the organization, learned the business inside out, served in a number of different roles, developed a passion for dual eligibles, those who are under-resourced, aging, or disabled, rather. And then I have lived experience with my own parents, helping them navigate prescription drugs, healthcare benefits, enrollment, cultural unknown types of services that are palliative and hospice now as well. And so that said, this opportunity came up and I wanted to apply and provide my vantage point and inform the committee and the great work that you all do. So thank you.
Thank you. Thank you. Welcome. Welcome. All right. Committee members, you have received draft minutes from our April meeting to review, so we'll go ahead and get into our business here. If you could please take a moment to review those minutes for any errors or omissions. And folks on the virtual part of the meeting, committee members, if you please raise a hand or make a comment if you notice anything in those minutes. Okay, I'm not seeing any concerns. Apologies, I'm going to take some extra pauses because we have about half of the members in person today and about half of the members on the virtual meeting. So I'll make sure we don't miss anyone. Okay. All right, if there are no further revisions, do I have a motion to approve the April meeting minutes?
This is Ronnie. I move to approve the April minutes.
Thank you, Ronnie. Do I have a second?
I'll second.
Thank you, Kelly. Any objections? Okay, hearing none. Any abstentions? No. All right, the motion carries. Thank you. All righty, so our next presentation today, or actually I should say our first presentation for the public meeting, is from the Center for Healthcare Strategies Technical Assistance Opportunity. Before we get started with the discussion of our policy priorities for the upcoming year, we're going to talk about an exciting and time-sensitive opportunity to support the Oregon Health Authority in getting some technical assistance for one of our important structural priorities. I'll now turn it over to our staff, Sarah, to lead the MAC staff to tell us more about this opportunity with the Center for Healthcare Strategies Technical Assistance. Thank you, Sarah.
Sure. I want to talk a little bit about what we're going to call the access rule and technical assistance opportunity with the Center for Healthcare Strategies. Next slide, please. Okay, so y'all may remember, some folks who have been following along for a time, that last year the Centers for Medicare and Medicaid Services proposed the access rule. And in April 2024, so just last month, CMS finalized that rule. And in May of 2025, or actually even a little later, states must complete implementation. Next slide, please. So I'm just going to go over very quickly some of the highlights of that rule. It creates a beneficiary advisory council made up of consumers and caregivers. It mandates that 25% of the Medicaid advisory committee members be members of that beneficiary advisory committee by July of 2026. It directs that OHA have bylaws for this advisory committee or council, actually, and it instructs the Medicaid director to select members for the Medicaid Advisory Council and the Beneficiary Advisory Council. That's a little bit different from how we do things now, where the governor appoints Medicaid Advisory Committee members. And I imagine, obviously, this is a discussion we will have over the next year as we are putting these rules into place, but I expect we will continue to have the members of the MAC, since it's in Oregon legislation, be appointed by the governor. And a change for both of those committees is that it limits the number of terms to one consecutive. Oregon can decide the length of the term. So those are kind of the significant changes in the rule. Next slide, please. So I think what's really important about that is that underlying each of those things is a number of questions that we have to come to an understanding about as we implement the rule over the next year or so. And we have an opportunity with the Center for Healthcare Strategies, which, as you can see, is a group that exists to help strengthen the healthcare system, especially for people served by Medicaid. We have an opportunity with them to receive technical assistance. So Oregon is applying for that. And we'll talk a little bit more about that. Next slide, please. So this technical assistance is to help states support, to help, well, Centers for Healthcare Strategies wants to support Medicaid programs in building their beneficiary advisory councils. They're going to choose up to 5 states to participate and provide technical assistance. So on a monthly basis, meeting with staff across the agency about how to make this work, and meeting with having them meet also with other states so that we can cross-pollinate best practices. But I think particularly exciting is that what comes with the re-granting opportunity, so that we can work with a community partner or community partners to help really build this from the community, right? And not have and really be in partnership with community in a way that maybe we haven't been able to in the past. So that it's not an OHA dictate, right? It's really something we're doing in partnership from the community. Next slide, please. So again, the project objectives, I think, align really well with things that we want to do in Oregon, increasing state understanding of member engagement and how to really work with these advisory groups, support states in partnering with a community entity, which I think is something that aligns well with our goals, not only with the MAC and the current subcommittee, but also with OHA's larger goals of achieving health equity, helping us in OHA create internal change and increasing our organizational commitment to doing this kind of work, and building internal staff capacity to ensure that we are able to take input from people in the community, from our members, and translate it into program and policy design. So next slide, please. They have a request out for applications. You can see the timeline here. I think the important piece is what I would like to ask from the MAC is the endorsement of a letter of support. And I believe you all received ahead of this meeting a copy of that letter. It essentially briefly outlines why this aligns well with MAC goals, and that the MAC supports OHA's application for this work and will be supportive of the work going forward. And I think that brings us to questions on the next slide. Yep. So I don't know, we're probably running short on time, but if there are questions.
Yeah, I just thank you, Sarah, for kind of doing that quick overview of the grant opportunity that would, sounds like, enhance our ability, enhance the staffing capacity, enhance some financial opportunities to reach into communities and build connection and reimburse different activities of different members in different ways, and a lot of technical assistance and learning from other states. I think I summarized it. Do any other members have questions about what potentials might be in the grant or about the application process?
I think my question is less about like, this makes sense to me. It's more about if the grant doesn't come through, what's the strategy to do all of the objectives that were outlined? So that's probably a future conversation.
Yeah, that is I think that's right. I think that is a future conversation. I mean, we're going to have to do this work whether we get the technical assistance or not. So I think it would be stronger if we had our application would be stronger if we had support from the MAC. What happens next if we don't get it is, we come up with a plan for how to get the work done without it. But yeah, I hope that answers the question. David?
Yeah, great question. I had the same question. Does the grant come with, so if we were one of the states selected, is the grant automatically provided as one of the states being selected?
What the RFA, the request for applications, says is that the states that are selected will receive up to $25,000 in grant funds. So for re-granting. So I assume that if we're selected, we'll get at least some of that money. I hope we will get the full 25 now, but yeah, that's what I know about that.
And then the second question, you mentioned something about MAC members being appointed in legislation, but the new access rule somewhat changes that. Do you foresee it being changed?
I assume what would happen is that what currently happens with our nomination process is we take in applications, we have a small committee of folks who review those applications, and then we forward who we think is we would like to meets the criteria for the seat that we're trying to fill. We forward that to the governor's office, and then the governor's office may choose to appoint that person. What I imagine will happen is that we'll have a process where we still have some sort of selection committee that forwards names to the Medicaid director, and the Medicaid director will then forward those names to the governor's office.
In our current statute, if we were to remove, if we'd have, that's a statutory requirement that the governor do the application just for other members. So it's in our statute. All right, any further questions? Okay, if we, online, any questions from MAC members? No? Okay. Well, with that, I think I'm seeking a vote. So if I could get a motion. to
Motion.
approve. David, you would move to, thank you, to approve that letter of support for the application. Do I have a second?
This is Ronnie. I second.
Thank you, Ronnie. Any objections? Any abstentions? All right. All in favor? Aye. Okay. Motion carries.
Thank you.
All right. So we are now chugging along to our next presentation. That is the OHA goal of eliminating health inequities by 2030 and strategic plan preview. So now I'm going to turn it back over to the two Sarahs, our own Sarah, who will share some questions to consider as we go through our deliberations today and into the future, and to Sarah Dobra, who serves as the Deputy Director of Oregon Health Authority's External Relations and the manager for Ombuds, Innovator Agent, and Feedback Programs. We love our ombudsman. Wonderful. So thank you, Sarah W. Are the Sarahs ready to present?
Sarah's are almost ready. I am having a little bit of technical difficulties, so
Oh, okay.
sorry about
We'll
that.
give the Sarahs a pause with the idea.
Sarah W., you're able to present the slides though, to confirm.
Is the presentation that I received yesterday the final presentation?
I think it was a live presentation. I can email it to you right now to confirm.
Yay.
Sorry for that technical pause.
Everyone get your notepads and your pens ready.
So essentially, I think folks have the questions from our handouts that went out to you, and we will drop into the chat for anybody who doesn't have this. It is available on our website, or possibly not.
I got it.
Okay.
It's in the chat.
That's great. So it's available in the chat. We put together a discussion draft of guiding questions for equity analysis. I'm going to go over them quickly, but I think the point here and what we really want to just kind of think about is when we are thinking through policy and program changes, are there some questions that we as the MAC want to be asking ourselves to help us put these in the context of the OHA strategic goal of eliminating health equities in Oregon by 2030. And I'll just remind folks of our health equity definition. So Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. So we have a number of questions to consider when reviewing policy or program change. We want to think about, I'm going to suggest that we want to think about things like, does this change specifically address or affect populations that have been historically underserved? And we would want to identify those populations. We'd want to identify what it does to address barriers. We would want to spell out if it doesn't do anything, if there's some way that the proposed policy should address those specific populations. We want to think about whether the solution that the policy or program change proposes would work towards eliminating barriers to accessing necessary healthcare services or benefits, identify the barriers, identify the populations. Are there going to be fiscal needs to recognize the potential changes? And if there aren't any effects of that policy that would address inequities, what identify barriers that would continue to affect access, right? And identify the communities that could be negatively affected. And finally, it's possible that the effects of a new policy would actually throw up new barriers, or in which case we would want to identify those and talk about how we think that mechanism works. So another key question that we might want to ask is whether the solution involves identifying or reporting on health inequities or on health equity, and then really, dive in, ask OHA to help us understand if OHA can ensure that there's disaggregation of data to reveal those inequities. And if there's not, how the reporting should, how we're going to include the data that reveals those health inequities or equity reporting. So a few more questions we would want to ask about community and partners that we should engage when we think about this program change. We want to think about if there's a way to incorporate requirements for community engagement. Are there changes that we could make to reduce or eliminate negative outcomes and increase positive ones for the affected populations? And overall, given the responses to the questions, to what extent does the proposed policy or program change address the goal of eliminating health inequities by 2030? So these are just, again, questions for us to discuss. For now, I just want to kind of put them, I think this is going to be an ongoing discussion for us. For now, I just want to have them in the back of our minds as we go through the rest of our deliberations today. And with that, I'm going to hand it over to Sarah Dobra. who many of you know from her work coming to us with the Ombuds team. And
Thank you.
let
Thanks,
you introduce
Sarah.
yourself.
And you have the slide deck in your email if you're able to share that by chance. Oh, I just sent it to Sarah Weatherson. I didn't send it to you, Jordan. Sorry about that. But I'm
All
Sarah.
right, yeah,
We're
that's the,
multitasking. I'll let you forward it right now. Sorry. No worries. I'm Sarah Dobra. I use she, her, Aya pronouns. I know many of you, and for those that I don't know, I really just look forward to, being available to you. I wear too many hats at times. So I will be here next month in my hat as a manager of the Ombuds program to present our year-end 2023 Ombuds report, which will also focus on health equity. So I just say that to help support your ongoing conversations as MAC. Here today, I am here to give an overview of the last more than 6 months that OHA has done, but really particularly intense work for the last 6 months to develop an agency strategic plan, and also talking about some of the history around that. So the slides will catch up. I'm comfortable just chatting with all of you. Feel free to, if you have questions along the way, ask. I may say I'll get to that, or I may pause there. So I'm very comfortable just having conversation, both in the room and with those virtually. I can't see chat, so just jump in if you are a MAC member virtually and have anything to add. So the governor, and I can see chat. I may not track it, so it's okay. You can still just interrupt or flag. The governor asked each state agency to develop and submit a 3-year strategic plan by June 1st, 2024. I don't know who's counting. I really didn't think June was next week, but that is. So OHA is in the process of finalizing for submission to the governor a 3-year strategic plan. The parameters put around that were that one goal must be tied to diversity, equity, inclusion, and one must be focused on the tribes. OHA chose to base our entire strategic plan on our 2030 goal to eliminate health inequities, as Sarah just read that goal to us, or the really definition there. And then really critically, this was a fast-moving timeline for us as an agency developing this 3-year plan, and yet community engagement is so critical. And so we really recognize that we have ongoing and iterative community engagement through so many points of our community, our Ombuds program being one example of many. And so both focus strategic planning development on previous formal community engagement done and ongoing iterative relationships. And I'm on slide 2, if you go to that, Jordan. Thanks so much. Appreciate it. And then really also recognize that, one up, I guess that's, if you go one more slide up, no worries. Then other direction.
Oh, okay.
There we go. We got it. We also just really recognize that in the plan implementation for the next 3 years, that ongoing community engagement, that iterative process will be essential. So part of the plan does include just strengthening OHA capacity for meaningful community engagement in alignment with our health equity definition. We're calling that phase 2 of community engagement. This means more tangible, practical to me of what that means. We can go on to the next slide. And this, as I alluded to, really builds on the last 6 months of work, really builds off work since right around when I joined the agency, actually, the last 5 to almost 6 years of work. And that development first of our overall agency mission, vision, values, and a performance system in which we really measure and try to match up our work to our outcomes. I remember being in the room in 2019 when our Oregon Health Policy Board adopted our health equity definition that Leanne Johnson, our Equity and Inclusion Director, brought to the board, and then directed OHA to adopt that. So if I think about this, it's our commitment, and yet we are newer in this process. We think this was, actually put in place as a definition less than 5 years ago. In 2019, in addition, there was a lot of very formal community engagement that went on, particularly led through our community partner and outreach program, and our equity and inclusion division to really think about strategic planning for a formal strategic plan. That strategic planning that occurred at the end of 2019 and 2020 was actually as COVID was beginning. And the outcome of that was we really said OHA's strategic goal is to eliminate health inequities by 2030. And then rather than jumping into operational plans, goals, and outcomes, we sort of hit the ground running with COVID and struggled through how do we make that operational? How do we make health inequity address health inequities and eliminate them operational in COVID? And I think there's data indicators, programs, areas of our COVID work that show where that was really leaned in and intentional, and also gaps in that, but thinking through that history there. And then that ongoing community partnerships and feedback, continual relationship, through many of our external relations division teams, but also throughout the agency. And then taking us to January of 2024, where we began this formal strategic planning process at the request of the governor. So thinking, knowing your history, where we're at, where we're going is important. We'll go to the next slide. And this is a little bit more details of the same, just what the last 6 months have looked like. And that has really included developing, reiterating that mission, vision, values with strategic goal around health and the health equity definition with previous work. As part of the strategic planning process, different deliverables included a strengths, weaknesses, opportunities, and threats, or SWOT analysis. Also PESTEL analysis, which was new to me. It stands for political, economic, social, technological, legal, and environmental. So what are those other factors that affect how the Oregon Health Authority does our work in the community? From that, we developed SMARTY, so specific, measurable, actionable, realistic, time frame. And I&E stands for equitable, and I should have written out the I because I don't remember today. I came unprepared. Really writing out specific goals and then thinking about measures and beginning our tribal consultation process as a formal process. Thinking about resource planning, monitoring, evaluation. We are in May, finalizing the document. I was in a meeting for that this morning so that it can be submitted by the 1st to the governor's office. And then we will really move forward to implementation. How are we doing? Any questions so far? Well, next slide. Just a little bit about the governance structure as it's helpful to you. I've been really just humbled by the breadth of wisdom and commitment by OHA staff at so many levels of our agency to support this work. There's a very formal project governance structure. Dr. Hoffey is our executive sponsor and ultimately makes those final decisions on that. There is a larger sponsor committee, the formal tribal consultation process. And then really we've had different subject matter experts and teams who have gone in depth to develop the different goals and a core project team. So I've just been humbled by the wisdom and commitment to ensure we set a strategic plan that can address and eliminate health inequities by 2030 and meet the needs of those we are here to serve in Oregon. And really want to express gratitude to staff at so many levels of our agency who've done that. We can go to the next slide. This is just a little bit more that approaches to engagement. And, I think it's the area, being part of the external relations division, I do think about a lot, but a little bit more of that history, the iterative process. Sort of the last two top stairs are looking forward rather than past work. So that's that continuing to have continual engagement loops with communities and partners to show how feedback has influenced the OHA strategic plan. So where have we been? What have we already heard? And how has that influenced where we are? And then where we're going. And I think, I would suggest that one area you could think about is how is MAC an essential part of that feedback loop and part of the plan. So planting seeds for future conversation there. Well, we can go to real quickly. We can go to the next two slides. I was going to focus on our health equity definition, but for anyone who does want to see that on the screen as Sarah so kindly read it, I do think it's I'll pause for anyone who just wants to think through it. It's what Sarah read earlier. We can go to the next slide if that's okay. How is this playing out then in what is shaping to be what will be submitted to the governor? Specifically, there are 5 goal areas. The first one really being transform behavioral health. The second, strengthen access to affordable care for all. And again, I might suggest just that might be one for the MAP to dive into further in alignment with some of your values throughout the course of this year. Achieve healthy tribal communities. Foster healthy families and environments. And that primarily is focused within our public health division, really thinking about local public health structures and outcomes. And then build OHA's internal capacity and commitment to eliminate health inequity. So recognizing even internally, looking at things like our hiring practices, diversity of workforce. I think what we heard, even some of the public comments, like, do we have staff with lived experience in the programs we're leading? Language access, culturally responsive services was something I think we heard time and time again when we were hearing from teams throughout the agency who are directly involved in communities. So even there's just this interconnectivity across all of those 5 goal areas. We can go to one final slide, and when I make sure I'm available to answer any questions too. These are a little bit more of that meat of those goal areas. I'll just read them to you because I think happy to give more context. And then under each goal area as well, there is between 3 and 5 specific strategies to support that goal. There are also specific outcome measures for each strategy. And that's going to really go into a public dashboard to show that continual movement and accountability towards those. And those are being finalized still this week so that they can be submitted. So transforming behavioral health really seeks to build a behavioral health system that works for every child, teen, adult, and family experiencing mental illness, or harmful substance use by expanding integrated, coordinated, and culturally responsive behavioral health services when and where people need them, guided by people with lived experience. And again, there are, I believe, 5 specific strategies to speak to achieving that goal. The second is strengthen access to affordable care for all and ensure that 100% of people in Oregon have easy access to affordable health care, prioritizing communities most harmed by health inequities. And so again, the strategies there look at not only Medicaid and focus primarily on Medicaid, but also understand things like the basic health plan and how do we have further expansion of coverage and really understand that disaggregated by REAL-D and SOGI data. This next one is that public health one, and public health wrote so clearly actually what their specific strategies are in their goal, which makes that easy for me. It's foster healthy families and environments that equitably promote health and well-being, especially among communities most harmed by health inequities, by expanding access to 1, preventive health services and supports, including for new parents and families before and after birth. 2, safe and accessible housing. 3, healthy food and nutrition. And 4, climate resilience. Our tribal goal is achieving healthy tribal communities. In honoring the relationship with the 9 federally recognized tribes of Oregon, Urban Indian Health Program, and other health partners, OHA commits to support the ultimate goal of achieving healthy tribal communities. This empowers tribal individuals, families, and communities across Oregon to achieve optimal health and well-being through a fully funded continuum of health rooted in traditional and culturally specific practices. And then finally, that infrastructure goal is building OHA's internal capacity and commitment to eliminate health inequity. And it speaks to establish, maintain, and resource the internal infrastructure and accountability mechanisms necessary to achieve, reconcile, and redress racism and other forms of discrimination and oppression that undermine the health, well-being, and community opportunities of people across Oregon. within that one is a specific strategy around community engagement to really put into practice sort of some of what I talked about earlier. That's really where things are at. That will be submitted to the governor next week. And I think should Mac really want to dig into the meat of the strategies, I would really invite you to put that as future topics to dig into that as well. But happy to answer any questions as well.
Is that the,
What?
is that the final?
That's, yeah.
Okay, great. So, well, thank you, Sarah, and thank you, Sarah. Are there questions from MAC members here in the room or online regarding this presentation and orientation to the emerging strategic plan? It's a lot for everyone to chew on.
It is.
I have a question about the Achieving Healthy Tribal Communities. Just reflecting back, there was a previous slide that in the timeline that was a Dear Tribal Leaders letter. I'm curious if that goal came out of response from tribal leaders and their engagement and sort of approval that it shows up in a state plan.
Yes. So this goal, and Julie Johnson, our tribal director for OHA, led the formal tribal government to government consultation with Oregon's tribes, and they developed that goal. And we're also kept informed of our other goal work. So that it does come directly from that formal government to government consultation process.
Sarah, I had a comment on the 5 strategies.
Yeah.
I did notice in behavioral health that it had a really excellent recommendation that it be guided by people with lived experience. I was sad to see that that was just not an overarching item for every single goal. You know, especially for our communities with IDD, with cancer, heart disease. The MAC committee members have talked a lot here about the wisdom of experience of people navigating an excruciatingly complex healthcare system, not just behavioral healthcare system. And I think that by only being in that one subject line is a little disappointing to me as a MAC member. I would like to see that as an overarching principle over all of the items. Not just behavioral health.
Yeah. I mean, everything is being finalized today. I'm happy to really take that feedback back.
Yeah.
And I know I'm part of the team leading the community engagement framework, so certainly can incorporate that because very well received feedback into practice in that specific area for community engagement as an intentional statement. But happy to carry that forward today for MAC comment.
Because I mean, I know that there's process to do that, but I think not just to call it out in one area, but to call it out in all areas is really important. Because healthcare, not just behavioral healthcare, the entire healthcare system is complex. And just people have lived experience with many different concerns with healthcare.
I have a question about the one that you identified as public health, which contains most of the HRSN priorities. Is there an alignment with the CCOs with public health around the delivery?
Yes,
those
there is
services?
members of the Medicaid team really helping to develop some of those public health areas that were there and did think about that. So I think even and I can't speak for 100%. So I think that's a good question to keep on asking, but I did see the intentionality in that planning. I say because I was on 3 of the 5 goal teams. So at least have a little bit of a view into some of the incredible work that staff did try to be thoughtful in, or at least recognize as a question. In practice, I think is the area to continue to ask that, but I did see thoughtfulness there.
Yeah, it seems to me that public health could take a really active role in helping to create community hubs around that work. Given our recent experience with COVID, public health is a really important partner that I don't think has received the funding they deserve to receive over the years, and that might be a really way to tie that together.
And I know one of the strategies under the public health goal really focuses on overall workforce development and infrastructure for local public health authorities. I don't remember the or know the exact wording, but there's that intentionality of building out the infrastructure there, not calling out one specific area, but building that up for many of those areas.
Good.
Any other comments? Well, I think myself, and then I would like to speak for other members, but I think we're very excited about being part of the Smarty Goals as MAC, and I'm sure many other of the advisory committees are excited to know what our role and responsibility will be in the Smarty Goals part.
Yeah.
Thank you.
And I'm just taking notes so I can make sure I bring those back. I will say, because you're meeting with Dr. Hoffey this afternoon, I know you have agenda there, but I think your comment around calling out these strength of the behavioral health goal might be appropriate to mention that. And I did let her know that any comment we had here that might be relevant for her to know about and address with all you, I would. So I'll flag that to you before 1 o'clock.
Well, it is one of the things we can be proud of in behavior. As a behavioral health person, it's one thing we can be proud of is that we've, in our sector, we have done a lot of work around that for many years. But I think it's such an important thing. It should be over. My belief is, as co-chair here, is just to bring up, it would be great to have it as an overarching component to all of the goals, that it's member informed and person with lived experience informed. Okay. Any further questions from anyone online? I think we're headed into lunch break. So thank you, Sarah and Sarah, for your hard work. And David, do we have anything else?
If I can just kind of set the stage here, we had, thank you, Heather, and thank you, Sarah, for your presentation. So we had originally identified a few minutes to sort of talk about, do some brainstorming on sort of how the MAC approaches the health equity conversation. And what I would like to do is just sort of get you thinking in the next couple of minutes, so that you can kind of carry that forward as you're having lunch, and then as we start to get into our policy priority discussions. And so to sort of set that stage, I thought what might be helpful is I've been thinking about sort of the work that the MAC does, and sort of putting that into 2 buckets. It's not a comprehensive list by any means, but thinking that many of those things sort of fit into one of 2 buckets. The one bucket is sort of the reaction, analysis, feedback on OHA developed policies, data that OHA might be producing, et cetera, that is impacting OHP members. So they're bringing you something and saying, you know, here's something we're considering, here's a change that we're making, here's something that's coming out of federal legislation, whatever that might be, and asking for your guidance, your endorsement, et cetera. So I think that's one big bucket of work that the MAC has. And then I think the other one is this more sort of generative stuff, where you're really looking at what are the policy priorities of the MAC as a committee. And that's what we're going to be talking more about this afternoon. And where do you want to focus? And then as you're putting those together, how are you evaluating health equity in whatever policy proposals that you might put forward to the agency? And this is the piece that I think will be really important for you to think about in terms of what tools, what sorts of questions would be helpful to ask as you're putting those policy recommendations for those reviews together. And a couple of things that come to mind for me are sort of thinking about, you know, how this hits the person, an OHP member. Right. So if you're thinking from sort of that OHP member perspective, and whether that's, so you'll want to think about how you do that, whether that's, you know, looking at data, and if so, like how are you, is that data that's available, and how do you communicate and coordinate getting that with OHA or wherever it may be? Or is it just sort of making up sort of use cases? You all have, you know, excellent backgrounds in you've experienced sort of how particular policies have impacted you in the past. So thinking about use cases where, you know, as someone sort of walks through the system as it's built, or as you're proposing that it be adjusted, how might that impact them, and how does it work, and where does it not work? And, you know, looking at, you know, that's for everyone, looking at it through that health equity lens, you know, for someone who is maybe, you know, in a a group that experiences health inequities more likely than other groups? How might that impact them differently? So just sort of thinking through those things. Sarah Weatherson shared some sort of questions that you might ask yourself, and so I would encourage you to kind of reflect back on those. And what I would imagine would be helpful is like a toolkit or something that you work through with each sort of policy recommendation that you're putting together that has those questions, and it's like a checklist. That you've thought this through and you've developed sort of answers that are palatable, that you think will put that health equity, move that forward. So anyway, as you're having lunch, sort of think through what those questions might be, what those approaches might be, and then we'll talk a little more about it as we get into some of the policy discussions, and then certainly as you do your work over the next year or so. So with that, it's 12:10. I think we're going to take 30 minutes for lunch, and so we'll be back here at 12:40. Is that okay, Heather?
Yeah, I think that works well. And our two staff members, so folks on video, you can sign off till 12:40. I think that sounds good, David.
Okay.
Yeah.
All right, so we'll see y'all back at 12:40. And as a reminder, people who are here in the building, the lunch is in 137B, which I think is maybe like the second door on the left as you go through
Down the hall down there. Okay.
All right.
Thank you, folks on the video. Thank you. Be back soon. I think this is still on, so Sarah and them will.
going to get processed as two separate cost-sharing payments for the patient. And while the insurance plans more often than not ask consumers to pay a copay or a set dollar
for the MAC as a whole. Want to have some discussion about that, make sure that that's resonating with you all, and then start to dig into a little more detail about each of those and what that might look like if that were an identified work priority for the MAC over the next year or 2 or 3 years. So if you want to go to the next slide and then the next slide. So as you remember, or maybe you don't, but there were a number of identified sort of policy priorities to choose from on the survey that had been identified by you all, I think, and by staff as sort of the things that were on the radar for folks. And you can see there on the left, those are the ones that you had to choose from. There was also an opportunity to provide, if something wasn't there that you thought was missing and would be a priority, then you could provide more information about that. There wasn't a ton of those sort of additions, so it seems like for the most part, the ones that were selectable were a reasonable group. So the way that this is put together is you look at the top one. And the other thing I wanted to mention, just by reminder, and for folks who are listening in that didn't see the survey, you were asked to rank them. So you put your top priority in slot 1, your next priority in slot 2, next 3, etc. And so what you get from that through some sort of weighted scoring is that you have, priorities that get ranked at number 1 get sort of more weight. So if lots of people rated that at number 1, then you would see that probably rise to the top. But it would also be true that if a handful of people rated it as number 1 and lots of people rated it as number 2, that also might sort of float to the top. So the ones that, so this is kind of the order that those presented in after that survey analysis. So right at the top there was Medicaid waiver implementation. And that includes the health-related social needs. And we've already heard lots of references to that in our conversations thus far. It's definitely front and center, I think, and some exciting opportunity that Oregon has to lead really the nation in sort of these types of things being able to be funded through federal Medicaid dollars. Next was eligibility. This broad category, but included continuous enrollment, extended eligibility, and looking at Medicaid eligibility possibilities for seniors. Next was CCO procurement, sort of the shorthand, I think, is CCO 3.0, and really looking at what the next 5 years of contracts with CCOs might look like. And then the last one there in sort of the top 4 is network adequacy, and looking at, what does that landscape look like in both rural and urban areas for those provider networks that are available to Medicaid participants, OHP plan members. And is it adequate? And our CCOs assuring that people have access to providers. So also on there, you see is for some reason it's not showing up, but there's a couple of other things here. I guess they're just down below. So MAC and the OHA Ombuds program, including member complaint data is next. Then there's non-emergent medical transportation is next. DME is the second to last one. And then the last one in terms of priorities for coming out of the survey is provider directories. So if we can go to the next slide. So this is just a little bit different way of looking at the survey results. And so what you see here is sort of a heat map or intensity of the interest. And so it's kind of hard to see it on here. Hopefully if you're closer and can study this a little bit, there are varying colors of blue. And so the deeper the blue, the higher number of where that was ranked, and then the higher number of people that ranked it in that place. So you see down at the bottom axis there, 1, 2, 3. So that is representing, people that put that in first place. That was their highest priority. Next, people that put that in second place, that was their second highest priority. And then you can see by the different colors how many people, you can kind of get a sense whether it was a lot or a few as the color sort of declines. And so this was very similar results, and I think we still sort of end up with the top 4 being the top 4. But for this one, that CCO reprocurement is at the top in terms of most people listed that as sort of 1 or 2 in their policy priorities. So I guess before we leave this slide, because this can be a little bit confusing, are there any questions or comments, or where we're going to go next is starting to dig into those top 4 priorities. But I want to make sure that this is understandable to folks. So any MAC members that have questions, comments about either of these? Okay. All right. So let's go ahead to the next slide. So these are the top 4 topics that sort of floated to the top. The Medicaid waiver implementation, eligibility, CCO procurement, and network adequacy. And so I want to start thinking about, I guess, how does that resonate with folks? Is this, I mean, it's based on the input you gave individually, but it's also, what does that look like collectively? And so as you think about your own priorities and the way that you answered this, does this look right to you in terms of areas that should be focus for the MAC? I'm seeing lots of head nods, so it seems like those sort of different ways of looking at this are sort of getting us to the right place in terms of digging into this a little more. So Caroline.
Hi there. I had a question about the Medicaid waiver implementation and eligibility, wondering what people's concerns were specifically about that. Like, what about the Medicaid waiver implementation do people think we need to continue working on, given that there seems to be, from my understanding, and I may be totally wrong, but that there is a planned out timeline process in place. And I'm wondering what is missing? What do people think we need to be doing? And similarly, what the concern about eligibility is it, because I know we have had expanded eligibility in the last couple of years. And so I'm curious what the concerns are about those two.
Yeah, so that's a really great question, and one that I had as well. And I think some of that may be some context within some of your previous conversations. But what I was intending to do is, once we get through sort of this presentation and get to our sort of brainstorming, is to look at that very question and start to look at when you think about waiver implementation, what does that mean in terms of the MAC work? And so start to do some brainstorming about that. And then we hopefully will get a better sense from all of you about what that means, what those concerns are, what the work would be, et cetera. So David, did you have your hand up?
Yeah, thanks. Similar question. Assumption going into ranking was that there was some area of concern. And so the way I guess I approached the survey was what I thought might Oregon's biggest challenges be, but I didn't have any hard data. So so similar to Carolyn's question about just those two, I had just an overarching question about all of them, but so that was it.
Great. Yeah. And I think that will be really important as a first step to, sort of figuring out what those priorities are. And then certainly as you start to develop ways of approaching this and making recommendations for program improvements to the agency, then you'll want to get more and more focused so that those end up being SMARTY goals. They're really actionable and understandable and relevant and timely and all of those things. All right, Hillary.
From my perspective, when I was completing the survey, I didn't necessarily have concerns around the Medicaid waiver implementation and eligibility, but to me, those are really focal points for the rest of everything that we discuss and focus on. So I think those are really central to everything else. At least that's what I was thinking when I was completing the survey, and one of the reasons that I think it's appropriate that those are our top two.
Great, thank you. That's helpful. All right, any other thoughts on those? Okay, we got a couple more slides on here, and then we'll get into our brainstorming piece. So as you start to think about sort of what's the capacity of the MAC to take on this work, right? And each of these topic areas can probably be divided into lots of different subcategories, and lots of work would be involved in any of those. And so as you start to think about how do you balance that work, sort of new work or focused work, with everything else that you have going on, both in terms of, as a volunteer committee. So you have, the rest of your professional and personal lives. And then there are certain duties that are spelled out in both sort of federal and state statutes and regulations and stuff that the MAC needs to do. And so want to look at what's the capacity and how much work will each of these be, and start to map that out in terms of how you could take that on. So, and as a reminder, here are some things that are really on your agenda, your sort of task list of things that you need to get done, because it like I said, it's for whatever is the driver, it's sort of a must-do work. And that's 1115 waiver updates, implementation of CMS federal rule changes, consulting on the quality strategy, reviewing or consulting on CCO marketing materials, and all the work surrounding the ombuds report, and what that's looking like, and the updates and changes that are being made there. There's probably other things that are also must-do work, but these are sort of the big sort of categories, I think. All right, and then the final slide here is looking at sort of ways to approach those policy priorities. So if you start to think about what does the MAC work look like in terms of addressing and developing recommendations to the agency around those 4 policy priorities, or 3 or 2, depending on what that capacity looks like. And so these are just some things that you all have done in the past, some ideas about things that might make sense for your work to be in terms of addressing those policy priorities. So it could be listening sessions in off months. So when you, so part of the, when you're not meeting, is that right, Sarah? So when you don't have a scheduled MAC meeting, that is an opportunity to have a listening session where you're getting information about certain things. You're hearing from different groups about, concerns, strengths, weaknesses, those types of things that might be in the current system. You can create subcommittees to research and make recommendations. And so this would be really, looking at focusing some focused time for smaller groups where you can get some of that hard detail work done, and then bring those back to the full MAC for full discussion and final recommendations. You can request updates from the agencies, OHA and ODHS, about progress that they're making on, whatever those things might be, previous recommendations, federal requirements, et cetera. Or you can, look at things that other committees have done, other committees have recommended, and sort of build on that, whether that's an endorsement of, and the MAC thinks so too, or in addition to these things, you should also do X. So, and there's other things obviously that you could do as well. So with all that in mind, what I thought we would do is look at sort of timing and strategies, and start to brainstorm a bit on what do you all need. See if we have some common understanding about what the areas to address under each of these 4 topics are. So How are we on time?
So we have until 1:15 for this discussion.
About 15 minutes. All right, so maybe what we'll do, and you can probably take that slide down and we can kind of see people a little better. What I thought we would do, and then I'll get to you, Shannon, is take each of these and just do some sort of rapid fire brainstorming on these. I'm going to give you a sort of a set of questions to think about, and then we'll just hit them. And what I would say is we want this to be quick in terms of, we're brainstorming here. And so you can just, MAC members can just shout these things out. We'll try and collect those. We'll see if that works. Hopefully it will. And then we can go from there. So Shannon, did you have a question? I see your hand's down now.
No, I just had general information about, I know I picked eligibility as my number one, and I know that is a topic we were wanting to talk about, and I just had my reasons for that.
Okay. All right. Great. Thank you. Yeah, Heather, please.
I'm so sorry. I'm always hyper aware of people on the Zoom having frequently being on the Zoom. Is it okay if people can MAC members can raise their hands or put it in chat? If
Yes, absolutely. Yeah, great. So we would ask you to do that. All right, so we're going to start with the top one there, the Medicaid waiver implementation. What I want to hear about is sort of the what. So this would be the issues and challenges, opportunities, next steps, whatever that might look like in terms of what you were thinking, or you want other MAC members to be thinking about in terms of what does that mean, waiver implementation. Then we're going to go to how. So we'll spend a couple minutes talking about the what on each of these, then we'll go to how, in terms of what would that look like for MAC work to address these things, and then when. And this is really looking at sort of the duration to complete for the MAC. So not necessarily to have policy recommendations implemented by the agency, but your own duration. So is this a 1-year task? Is this a 2-year? Is this a 3-year? To complete, and then also looking at when would that start? When would that sort of plug into your work? So does all that make sense? Okay. All right. So Medicaid waiver implementation. So starting with the what. What are the issues? What are the things that you all want to see addressed here?
I'll just start with one. Just to acknowledge Chris's comment here about HRSN and it not being available to everyone. In the Medicare space, particularly for duals, there's a major shift in funding where plans who serve these populations may be pulling back on benefits. And so the what would be, I understand HRSN includes food, nutrition, and some other things. And so how might be, well, if folks are losing some services or benefits in that shift or shakeup, then how might we think about HRSN better serving a broader population, or those who might be, who currently don't qualify but may need some benefits or services? Is that?
I think so. So in HSRN, obviously, I think this is going to be a big one for almost everyone. And I think what I hear you saying, David, is really looking at, are there sort of unintended consequences or sort of a shift in funding streams? Because as you open up this one for HSRN, then maybe that shuts down. This is a question for you. If that's what you're referring to, then that could potentially sort of create people who were eligible for some other program in the past are not eligible for that program in the future. Is that what you're wanting to address? Or
Yes, it's just that some of the HRSN services are so narrow in terms of who they might reach. But for duals in the Medicare space, plans may be pulling back on some of these benefits. And so how do we broaden the HRSN reach to capture the folks who might be losing something on the Medicare side?
I see. Okay, so it's not necessarily displacement. It's really sort of reacting to the change in the landscape that's already happening for these other populations. Gotcha. Okay.
When I was thinking about the waiver and the evaluation work and all that, my hope is that for us as our work as the MAC, to making sure throughout the waiver period that we're using those guiding principles around, are the opportunities across the board, are we getting information that helps us as the MAC understand that we're leveraging the HRSN and the other opportunities in the waiver in a digestible way that we can ponder and provide feedback to drive towards the health equity and consistent access for all Oregonians, because we have multiple different plans and different approaches, but all Oregonians deserve the same access to the services. And are we getting the right data and information as the MAC to weigh in and just be supportive to moving the needle in that direction? So that's kind of my thought about the waiver is how is our ongoing contact over the waiver period and our feedback and opportunity to support the work informed. Does that make sense?
It does, yeah. And I think one of the things that that you talked about was sort of the data and figuring out, sort of what that data is, and then ways to get it. Does it exist? If it doesn't, what does that look like in terms of tweaks in what's being collected? Is it a big shift, a small shift?
Yeah, like David was saying with HRSN, we're starting with a small pilot population because it's a relatively small budget. And is it working? Did it work? Did it change outcomes? And if it did, how do we expand it to other other populations or regions that may be having, like you said, maybe there'll be a shrinkage of access in other places. And how could we leverage that? I think that's a good example.
Just another question, just because I don't know, but if we do find that it's not quite meeting needs, and I don't know if this is in the current implementation, if the populations who have been chosen, if that's a minimum or a requirement, because I suppose in this case, plans, if they had the ability, could quickly react and do more than the minimum. I just don't know how that's described, right? But that's just a thought.
I think that gets back to the data and reporting for committee members.
Yeah. Okay. So, I mean, I think of this in terms of, you talked about pilot, and it's really sort of proof of concept, it sounds like, in terms of, if we do these things, does it have these positive outcomes that actually, impact, help you hit the triple aim, right? Or the quadruple aim, wherever that lands, and really looking at what's the data to know whether that's working or not working. And is it available in enough detail and enough frequency to help you sort of adjust things as you go along? Is that?
Yeah, because I think, I don't know, for me, serving on the MAC, it's an opportunity for me to just be an outside set of eyes to be supportive of moving the work towards the vision. Just like any board, right? Yeah.
Right. So if you think about, so we've talked a little bit about, and this is just the start of the conversation on all of these. Obviously, we're not going to figure it all out in the next few minutes. But we talked about HSRN specifically. Seems like this is an area that the MAC will want to sort of take up and focus on, given the feedback. I've heard, as far as the how, it's really looking at sort of identifying data streams, and then having some presentations with that data to know how things are going with HSRN. What about the when? What's the timing on this that makes sense for again, this is focused on the MAC specifically and what the MAC is doing. Is this something you take up immediately? And once you do, how long? What's the duration?
I think we've got some time because housing doesn't come online until November. Nutritional supports aren't aimed until January. There won't be data to really react to for some time.
Okay. So if we're thinking about like sort of in broad terms, like a 3-year plan, I think our main focus is sort of the 12 months. But looking at sort of longer term, this one sounds like it's maybe starting like a year from now. Is that, or thereabouts? Is that fair, or maybe 6 months?
We can call in an expert too. I did notice that Steph Jerem is on the call if we need some more information. And I noticed that she offered that she's here for answering questions.
Yes, whatever is helpful. Hi, everyone. I'm Steph Jerem. I'm the waiver policy director.
And like implementing regular updates in our normal kind of fashion and developing a calendar, like you were saying, Kelly.
So is that timing that David was suggesting, 6 months or even longer from now, to start thinking about that next wave of monitoring that we'd want to do of waiver implementation stuff? Does that sound realistic, or would we, if we're looking for data specifically to look at for how that's implementation is coming along, what timeline should we be thinking about?
I think there's a lot of ways you could approach it. We are actively working on a monitoring protocol, which is a little bit more of our process tracking, including readiness for launch. So, it's, anticipating where we need to be at certain stages and some of the initial steps that are in place in order to make sure that launch is successful, as well as some of our there are like readiness requirements in our contract with CCOs that they'll sign and that will go live prior to actual launch. So there's certainly monitoring aspects of that. But if you're looking at like actual service utilization, who's getting served, those are things we're building out now to understand what we'll be able to get from like the first quarter and what that data lag is. So I do think we'll have some data in the first 6 months. Some of it may be like not as comprehensive as we want. For example, we launched climate in March 1st, and we've done surveys of CCOs to just say like, how many devices have you gotten out? How much outreach have you done? It's not formal, it's not come through claims, but we're able to get some information. So those are the types of things that we could certainly be providing, especially if you have very specific interests.
Steph, thank you. That reminded me, and maybe because we have some MAC members who are a little newer, just working with the waiver team, you bring up a good question about the timeline and activities, because one of the questions MAC members had for the waiver team was, yes, we have the outcomes of the person served, but we also would like to track the implementation and any opportunity and how that's going. And because that kind of ties into our MAC requirements around marketing materials and communications. And so it kind of is a place where we can do 2 or 3 things at one time. So maybe that's something to consider with Sarah and you about bringing information to the MAC to get our feedback from a advisory perspective.
Yeah, that would be great.
And I wonder, Steph, the information says community-based organizations. And right now in primary care, what we're experiencing is a lot of people coming to primary care asking, how do we access these services? Are you going to track where those requests are coming from? So we, because we kind of need to adjust our staffing to deal with all the requests we're getting. And I don't think that was I think it's an unintended consequence of rolling out this huge program, but it's something that we have to think about all the time.
Yeah, I hear you. And I do want to be conscious of like, we can answer these questions, but I also am happy to come do like a longer presentation if that's more helpful. And Charissa is on. She is our outreach and engagement lead for HRSN. I don't know if you heard that last question about providers.
Yes, absolutely. Hi, Charissa Young White, she, her, hers, and I am the outreach and engagement lead with the Oregon Health Authority. I think this would be a really great topic to bring back like Steph said, but my quick answer is yes, we are tracking that. As long as they are enrolled as HRSN service providers, we can track that. We can also track if a member has self-referred themselves, but we can't necessarily track if a primary care physician just verbally called the CCO and then the CCO connected with the member, unless that gets integrated into a person-centered service plan. So there is some nuances there that I think is something that we would love to talk about with you. So if you'd like to reach out to outside of the MAC, feel free to email me and we can discuss that as well.
I saw lots of nods here from MAC members at the table that they would love that, because many folks here are recipients of services or work within the system, whether it's physical health or behavioral health, and would love to have more clarity, it looks like, around how you're collecting that data, because that is a happy unintended consequence. People know it's happening and they would like access to it, but I think more opportunities for communicating the specifics and the rollout would be great.
And especially, I just want to call out that you can get paid for outreach and engagement. So for supporting these members, and that's a huge part of this benefit. I didn't call that out specifically. So I'd love to come back with that benefit in mind of how you sign up to actually get reimbursed for this sort of special HRSN niche of outreach and engagement, because I know you do outreach and engagement a lot in different ways. So anyway, I just want to call that out. And yeah, I'll have this on my calendar and can come back anytime.
Thanks, Carissa, and thanks, Steph. I do think that makes really good sense, and I think it's another sort of piece that we talked about a little bit in terms of approaches, but not directly on what might the work for the MAC look like. And I think this sort of gathering additional information from the experts that are working on it, on day in and day out within OHA, is going to be really important, and it'll be one of the places you want to start as you start to develop that. And I also wanted to make mention that I think that for all of these policy topics, Sarah has invited sort of the policy experts that are within the agencies that are working on this. So they're here, they're hearing you, and then also the one-pagers that were shared in advance of this meeting gets into, they're still high level certainly, but gets into some additional detail and then provides some additional resources if you want to dig even deeper into sort of what are the issues sort of from the agency's perspective in terms of what's facing the agency, what's coming down the pike, those types of things. So I think with that, I think we're at time for this conversation. I think that is that.
Oh, we're waiting for Dr. Hathi to join.
Okay, so do you want to just give me a?
Tom's going to let us know when she's on, and then so I think you can just talk until.
All right, cool. I'll look for the high sign then. So let's go ahead and move on then to eligibility. Laura.
Oh, sorry. I was just going to make a quick comment. I had put it in the chat there about the HRSN benefit from a CCO perspective. It's Charissa and Steph have done a great job of helping us implement and roll out this benefit. It's a lot of work. And I would be happy to come back and update the committee on how this goes from the CCO perspective, because it's, we're the ones that are going to be working with the CBOs and contracting with them to roll out this benefit. So I'm just happy to update as needed from that kind of perspective as to how the benefit's rolling out.
Great, thank you, Laura. And I think that's another really great point. You have a lot of sort of internal resources here within the MAC, expertise, so people who are doing these things, implementing, sort of receiving these types of services. And so that can be a really good informational source for you on how things are working or how things are not working. Yeah, Shannon.
Yeah, just on the eligibility, which I thought I had heard was the next.
We are going there. Yes, thank you. Go ahead.
Okay. So for eligibility, and I know I've said this before, so excuse me if I'm repeating myself, but I know that our eligibility is based on federal poverty guidelines. And with Oregon being one of the more expensive places to live, it seems kind of short-sighted of us not to be using our own data to determine eligibility instead of using this overarching vague idea of what it costs to live in the United States. We need to be focused on what it costs to live here in Oregon. And if our goal is to expand coverage and eligibility to those that need it, which is my understanding of the goals of MAC and OHP in general, we need to be focusing more on Oregon's costs and understanding that our living wage is not something we're even close to meeting with our current eligibility guidelines. If we're wanting to make sure that people that are at risk are covered, we need to take that into account. The federal poverty guidelines, for what poverty level is, I want to say is a wage of something like $8 an hour, but yet to live here and exist as a single person, it's much, much higher than that. It's at least $10 more than even our minimum wage. So we really need to look at what our guidelines are and why we're using those.
Great, thank you, Shannon. And I would note that some of our earlier conversation around strategic goals from the governor and OHA was really looking at, regardless of sort of how someone is qualifying, this goal of making sure that every Oregonian has access to affordable health care, I think gets at the point that Shannon's making here. So, if there's a way to adjust that for a Medicaid eligibility, great. If there isn't, it doesn't mean that you wouldn't want to try to address it through these other measures. So, all right. So, Chris, I think we've got Dr. Hathi. All right, so I'm going to go ahead and turn it over to Chris, and then we may have opportunity to kind of continue this conversation. Heather?
I do know folks have their hands up if they would want to put their comments in the chat to make sure the staff could capture them for later conversation.
Yeah. Great.
Thank you.
Great, so I move into our next agenda item where I'm pleased to introduce Dr. Sejal Hathi, MD, MBA, who's the relatively new OHA director, started in January. Dr. Hathi came to Oregon, having served most recently as New Jersey's Deputy Health Commissioner for Public Health Services and its designated state health officer. Prior to that, she served in the Biden-Harris administration for 2 years as the White House's senior policy advisor for public health, leading various domestic presidential policy priorities. Dr. Hathi is a board-certified attending physician and has also held joint faculty appointments as an assistant professor of medicine at the Johns Hopkins School of Medicine and Bloomberg School of Public Health. So with that, Dr. Hathi, I'm going to pass it on to you for the next agenda item.
Thanks so much, Chris, and really wonderful to be here. Apologies, I could not be there in person. I had a series of medical procedures to take care of here in California. So flying back this evening and looking forward to joining you at a later date. I'm here, I would say, principally as an extension of the statewide listening tour that we've been conducting over these past few months. I'm eager to hear from you, to learn from you. I have read your most recent report, and I want to know what your expectations are of me, what your asks are of me, and what I can do to better serve you and support you in better serving our Medicaid population. So thank you for inviting me to this initial meeting. Hopefully this is the first of many such conversations, and I'm eager to hear what you have to share.
Great. Well, thank you, Dr. Hothy, this is Heather Jeffress. I'm the co-chair of the Medicaid Advisory Committee, and I think I'm also at my day job. I'm the executive director of the Oregon Council for Behavioral Health. So I know we've had a couple conversations, but I know you meet many, many people. So pleasure to meet you again. Today at our retreat, we really have been focused on starting to develop our work calendar for the next year, and we really appreciate your time with us here today. As you know, the Medicaid Advisory Committee is both a federal and a state advisory body. And so we're really excited to really think about the big picture topics of using this committee's wisdoms and talents and treasures. We have such a great group. It was really fun to spend time this morning learning about each other and our passion and mission and wisdom around this work. And identifying some particular topic areas, but all of those areas really being held to that vision of eradicating health disparity by 2030. So when I talk about each of these individual items, always just reminding everyone listening in that that is an overarching consideration, and we're developing some standards in here as an advisory body to test how we get information and how we will assess information and how we will develop our recommendations and our thoughts around being a supportive advisory body to the entire OHA team and the system of Medicaid in Oregon to excel and achieve that vision as much as we can help. So that's kind of our overarching goal. I don't know if any other committee members, if I left anything out around that. Is that good? Okay. All right. And so our topic areas that we really were looking at include looking at the waiver and making sure, particularly the health-related services and other items in the waiver, how effective are they? Where are areas that can be leveraged? Where are areas that unexpectedly may or may not turn out the way we expect? How do we get that information? How do we, as a committee, support the OHA team and serve as an outside set of eyes to move that needle? Also around eligibility. We had some excellent comments, which I think will tie into the work around the bridge plan and the future basic health plan, and also other expansions around serving different diverse communities and giving them access to health insurance. So how are we as the Medicaid advisory body supporting that expansion and vision that all Oregonians, as many as possible, get access to equitable healthcare, including behavioral healthcare, all forms of healthcare. And then with that, also that the Medicaid committee members are very interested in ensuring that the CCO procurement process, it really reflects this in how it's actuated, how that language is utilized to really move that vision to action, right? So okay, I'm getting nods. It's always hard to be the secretary, right? And to make sure you're getting everybody's good, wise thoughts. And then also one topic that has come up over the last few years, particularly, and also in the Ombudsman report, which we work very closely with our amazing Ombudsman's division. So thank you for supporting that team. They're wonderful. Is really around network adequacy. And again, making sure that all Oregonians have the right service at the right time in the appropriate manner and cultural responsibility and language. And so we really are focused on that for all Oregonians here at the MAC. So those are items that will definitely be on our calendar and tie into our required work items. The required work items include looking at waivers, looking at marketing and communications, because of course, if you don't know about something and it's not communicated well, then you will not have access to it. And also making sure that we're achieving our vision. So those are kind of some of our big topic items that we were talking about today. And then we had some smaller recommendations that we had an excellent presentation today about the strategic plan that you and your team have been working on for the governor. So that was really exciting to get a little lens into that. So I know I had one item, and I think there was a couple other items from MAC member. Maybe would you like to make comment on those things, or would you like to hear a couple specific things? before you go into comment.
Specifics are great.
Okay, cool. I don't, Kelly, I think, did you go? No. One that we saw the 5 strategies, which we thought were really excellent. And one that I noticed is that on the behavioral health, there was a really excellent recommendation that all behavioral health strategy is guided by people with lived experience. And as the Medicaid Advisory Committee, we were like, that'd be nice, and as me, that actually all those items have that's not just for behavioral health, that's actually for all 5 strategies, that all 5 strategies are guided by persons with experience, lived experience with that area. Because we know that just like behavioral health, physical health also has folks who have different struggles and challenges in accessing care and to get to that equity vision. So we would ask that be moved for all the topics, not just the one. We thought that was a great recommendation, but we'd like to see it across the board. Any others, MAC members? They're so quiet now. So that's our work. We're excited to have time with you and to give to provide you with support and recommendations and support your entire team, and really appreciate all the hard work that you're doing at the Health Authority and bringing the team together and getting things done.
Thank you so much, and really appreciate the recommendation to ensure that the policies and programs that we are advancing are indeed rooted in the lived experience of the communities we're seeking to support and represent, and think that is a principle that is at the center of our equity vision, and really that we seek to hold close and abide across all of our work already. But I do, agree that incorporating it more explicitly into our draft as an overarching narrative frame and approach would affirm both to our staff and to the public that is indeed our intent. And so I can certainly look into doing that. I think amending the text of this individual goals, candidly, at this stage, 2 days before their due date, given the many layers and iterations of subject matter experts and staff advisory groups that have shaped and reshaped laboriously their substance over many, many months, would be challenging, if not impossible. But I think in introducing those goals, we certainly can, again, incorporate and affirm that framing.
So this is David Simnett. Do you want me to?
Go ahead, David. Yeah.
Okay, thanks. David Simnett doing the facilitation of the MAC retreat today, and just wanted to check in, Dr. Hudley, if there are other thoughts that you have that you wanted to share based on those other priorities that Heather talked about from the MAC. And then from there, I think we're going to check in with Dr. German on how those sort of align with OHPB work and OHPB priorities.
Yeah, no, I would say that I'm just looking around the virtual and in-person rooms, and I think you have an extraordinary group of OHA staff that I'm sure has already echoed and will have said what I may at a high level now say, but I think that your priority areas, which I understand align with OHPB priority areas, are very much a focus for us as well. And I do think, without delving into this at this moment, that the next CCO procurement in particular could give us an opportunity to better understand, evaluate, and advance CCO spending on social needs and strengthen network adequacy. And so very much looking forward to continuing that conversation as we dig into those bodies of work.
Anything else from the MAC members for Dr. Hathi? Questions? All right. So maybe we can check in then with Dr. German. I think Dr. German, you're going to talk about how those align with OHPB.
Yeah, well, thank you, everybody. And it's really a delight to join all of you in the last, I think I've joined the last 2 MAC meetings, and thank you for the opportunity and honor to be part of this group and this work, and hoping to serve as that liaison of the great body of work and attention that you guys are providing. You know, I think a lot of shared visions today, and I think Ms. Jeffries, your comment to the effect of, you know, moving the work towards the vision. I think our state has put in place a really remarkable vision that we got to hear a bit of a history, early part of the retreat today, with a focus on the strategic plan that was outlined today. I think OHPB shared a number of our goals, and the collaboration with what Dr. Hathi shared just now. I think the things that stand out to my observation of being a baby on the OHPB for the last 6 months and getting my feet grounded on that is working on the goals outlined by Governor Kotek, utilizing the mechanisms of the 1115 waiver and our strategic plan. But I think the 3 points that have stood out to me then in alignment in hearing your reflections on the MAC committee is the attention to the CCO procurement, attention to eligibility, and you know, the body of work that we have done as a state to move that with expansion of certain programs, attention to Healthier Oregon, the basic healthcare plan. I think we're doing some really remarkable work. So I'll keep my words short here, but really just looking forward to help be that connection with the Oregon Health Policy Board. I want to be completely available for this committee and the work you're doing, and love hearing great ideas and seeing where we can move that together. So thank you.
Thank you. All right. So I guess, are there questions or comments on any of that from MAC members?
This is Lisa. I just had a quick question. I don't know if this is a place to put it in, but there had been talk of having members of the community or people with lived experience on OHPB, but the call has gone out for applications a couple of times, and then that hasn't gone through. So is there still plans to make that happen?
If I can help answer that question. Hi, everyone. Steph Jerem. So the OHPB has very specific requirements in statute that has to do with membership and who represents and what sectors they serve. And so it is really tricky. I think we recognize the importance of having that voice, and we've tried to bring people in who can represent some of that voice, but I know that's insufficient. So some of that would be a statutory change in order to have an actual seat representing that voice on the board. So just for total transparency.
And can you link to that provision of statute that governs in the chat?
Steph, if you don't have that handy, we can track that down and put a link in the chat.
Thank you, Lisa. Thanks, Steph. Laura?
Hi, Dr. Hathi. My name is Laura McKean. I'm the Senior Director of Oral Health Services at All Care CCO, and I wanted to let the MAC know that we have been without a state dental director for quite some time now, and Dr. Hathi came down to visit us a few months ago. Maybe it was, maybe like 2 weeks after you had taken the position, Dr. Hathi, and you had asked what you could do for us. And I said, we really need a state dental director. And I think it wasn't maybe 2 weeks later that the position was posted. And now we're conducting interviews for a state dental director, and we need that guidance. So I just wanted to let the committee know that I was very thankful, and I really am appreciative and just thankful that Dr. Hathi is here. So thank you for doing that, because we're excited to have a state dental director back.
Laura, you and all of us here. So thank you too for sharing how much of a priority that was, and still is, to you and your community.
So I think we've got about a minute left, and maybe I would pose a question to both Dr. Hathi and Dr. German in terms of, it sounds like the MAC priorities that have been identified by MAC members are in great alignment with sort of OHA priorities and work and OHPB priorities. I'm wondering though, if there are any of those things or subcategories with under those that you would recommend that the MAC focuses on sooner rather than later. If there's anything sort of percolating, and I think, yeah, I'll just leave it at that.
Thanks. And sorry, I don't think I caught the first part of your question. Any subgroups under what specifically that you are seeking guidance on?
You bet. Thank you. So Heather had shared the MAC conversation leading up to sort of this discussion with you all on the priorities that had been identified by MAC members to work on over the next year or two. And so that's like Medicaid waiver implementation, CCO procurement, eligibility, and network adequacy. And so within those things, are there things that would be helpful to be concentrated on sooner rather than later from an agency or health policy board perspective?
Dr. German, I would be interested to hear what thoughts you have here.
Sure. Yeah, thanks, Dr. Hathi. Some things that stand out to me that I'm coming to learn in the committee work and the body of work that the MAC does, and what I think Oregon Health Policy does well is serve as a public face and to elevate the important voices of lived experiences and those in the community and those that are affected by the delivery of policies that we're putting in place. I think the connection of the MAC with a number of the CACs throughout our CCOs, and I think with respect to CCO procurement, not one CCO is the same throughout our whole system. Each has a different approach to community care. And I think attention to the voices and the ombudsman work can be reflected into making sure that we are continuing to optimize CCOs and their delivery of care, and holding accountability across CCOs is something that I've been thinking about. I think the MAC's connection to that body of work can bring that in shaping the policy that we think we need to put in place for the CCO procurement. It would be one reflection I have.
To you because of the limitations of this computer.
Thank you, Dr. German. I think that's wonderful, and I really appreciate your support. And I think that the MAC members here today and their conversation, I'll just reflect back my summary of what I've heard today is really in line with what you're saying, that this group of committee members really sees themselves as a place where we want to hold high standards for each of us to bring the voice of the community and drive actions that move us to the vision of supporting health authority and its contractors, the CCOs, and all of us as providers who are then supported by those entities to getting the work done and making strong change to create equitable access and remove health disparities as much as possible by 2030 here in Oregon, and to keep that going, not to let it falter once we achieve it, but to actually, sometimes that's the harder work, right? Is first you can make the goal, but then to sustain the goal, and how do we sustain that over time? So thank you for your work on the Oregon Health Policy Board and being the liaison, one of the liaisons to the MAC. We really appreciate your wisdom and input, so thank you. And thank you, Dr. Hoppy. I know I don't see you now. Your video is moved off the screen.
Oh,
But thank you so much
sorry.
for all the work that you're doing too.
No
I-
worries. You know, I would just say from my perspective, on network adequacy, I think this is an issue that obviously concerns Medicaid, but transcends Medicaid. I recognize I'm speaking to the Medicaid advisory group, but I, at the same time, think that this needs to be a coordinated approach, especially as we look at aligning Oregon's practice, for instance, with new CMS rules and federal mental health parity rules. How can we take a more unified approach across commercial payers and Medicaid to strengthen access to behavioral health care and primary care, especially in rural settings? I think this is going to be a problem that gets increasingly dire and is obviously impacted by the workforce shortage as well, and financial constraints under which many providers are straining to stay alive. And I would welcome any ideas, especially in advance of the next legislative session, recognizing that we are facing an austere budgetary climate. Nonetheless, any recommendations this group has for how we, in collaboration with DCBS, could do more there.
Thank you. That is very exciting. Thank you. Well spoken. Thank you.
I think we should invite people to give public testimony, since we said that we were going to have some time for that starting about 5 minutes ago. And Shannon, I do see your hands up. I don't know if this is something you can share in the chat, but let's open it up for public testimony to see if there is any additional public testimony. I will note that we did receive written public testimony, which, if it isn't already on our website, will be shortly. And I think it is actually on our website. So just people there, we can drop that website link into the chat as well. So I don't know, I'll check with my colleagues. Have you seen anything in the chat indicating additional public testimony today?
Hi, this is Carissa Bishop. I was able to stay. I wanted to reiterate that I gave my public testimony prior to the start of the public meeting today and want to make sure it's on record.
Thank you, Carissa. Yes, this is Heather, and we have captured your testimony and it is on the record. So thank you so much for reminding us and confirmed.
Thank you. Thanks.
All right. Any last, should we thank you for folks who may have been waiting? Anyone left that maybe want to do public testimony? I will pause. I'm a mental health clinician. I can pause for a long time. I think we have an appropriate.
As you continue your pause, I just want to again thank you for allowing me to join you. Say that I always welcome additional feedback and outreach by email or on these regional visits. I'm very excited for the work this group will do in coordination with the Health Policy Board and soliciting public and community input in advance of the next procurement. And just really thank you for your partnership and your support. I'm going to run off to my final medical appointment and just wish all of you a wonderful rest of your meeting. Thank you.
Oh, thank you, Dr. Houthi. Thank you for taking a little extra time with us today. We appreciate it. And I hope all goes well. All right. Well, I do not see any further requests for public testimony in the chat. I did not hear or see a hand or a speak go up. So I will say with that, time for public testimony is concluded.
Great. David, are there any next steps you want to recap or?
Yeah, just a couple of thoughts on that. I think that, we've seen really good evidence today of the depth of knowledge and capacity for amongst the MAC members. So I think that's really exciting, and there's lots of opportunity for you to help move the state forward in sort of Medicaid, in that Medicaid space. I think that as you look at coming out of this meeting, things to really focus on are sort of this further development of getting to the specificity level of what you would work on under each of these areas, and really looking at, what I would recommend is that you're, picking, 2 or 3 probably like digestible topics that you can address over, a 12-month, 24-month period, recognizing all of the other things that are on your plates, so that you're really giving that the sort of its due diligence and attention that needs to really come to those actionable recommendations for the agency. And I think what we heard today in terms of your questions and comments and some of the feedback that we got from, in particular, the OHA staff, as well as the Dr. Hathi and Dr. German, we're really looking at, as you dig into those, to invite the experts to help you sort of understand the landscape from an OHA perspective, because that's where the recommendations would go on things that, they're already working on, or they feel like that they have, things that they've tried in the past and maybe didn't work. Those types of things doesn't mean they can't be tried again, but, maybe a new slant on them. Getting that sort of building that body of information and getting informed in that way, looking at data and what data might be available to help inform the work that you will do, and then really sort of nailing it down in terms of a work plan, so that you have those detailed steps. And I think Sarah and other MAC staff can really help you get to those places. So I think in a nutshell, that's what I would say are sort of the next steps after today's conversation.
Great. I appreciate that. We certainly have a lot of work ahead of us. I did notice that Shannon put a comment into the chat, and if Shannon, you still, I think now that we've, attempted the public testimony and we're at this place, if you wanted to share something still, I think we have a minute or two for that, and then we'll close out.
That is awesome. I really appreciate the opportunity to say what I was going to say. When talking about CCOs and like coverages and the issues behind that and adequacy of providers, I think we do really need to take a big look at how we are requiring our providers to apply. As someone who is a doula and who has done the certifications to be able to get the Medicaid billing number, and then having to go through those processes to then also contract with CCOs, it's a big hurdle, I know, for myself. And in talking with other alternative care providers like acupuncturists and things like that, it is the universal hurdle is contracting with Medicaid, contracting with CCOs after that. It's a really big issue, and it's one of the main reasons why a lot of people in my profession and professions similar to that just don't do it. So that is definitely something I think we need to take a look at and see if that is something that's stemming from an issue with the CCOs and it's not something we can help, or if it is something that we could potentially provide guidelines for to help address the inadequacies that we have, because the inadequacy isn't providers not being available. There's tons of us. It's the ability to do that contracting and have it be a simplified process, and to have someone contact us back or even just tell us where we need to go, because that is an incredible maze to even try to figure out where you need to go to apply. Sorry, that's why it's not concise.
Great, but it's something for us to think about as a MAC. You know, when we're thinking about network adequacy, that's another piece of network adequacy and that we might want to take a look at. Okay. And then I think we're up to our plus delta part where we close out. So in the spirit of continuous improvement, I wanted to check in about what went well today and what could go better in the future.
In person is great.
In person is great. Yeah. I like it too.
This is Lisa. Zoom option is great.
This is Heather. I think we are getting better. I hope I get mutual feedback reiterating my feeling. I feel like we're getting better at balancing the hybrid meeting and taking pauses. Okay, thank you, Carolyn. And making sure, I see a little nod, making sure that we're leaving space for people to speak up that are virtual. Yay, okay. I think we're getting better. We're doing it.
This is David. I've got two. I appreciated, David, the way that you set up the what, how, and the when, and kind of scoping us and the time frame for what to take on and to think about capacity. And so I appreciate the way that you kind of set this up. And the second would just be that I wish we had a little bit more time to dig into that, but so that would be the second one. But
Anything online? Good, bad, ugly? From our MAC members?
Hillary.
Oh, Hillary. Appreciate folks in person are quiet. The background noise for virtual folks can be really distracting and make it difficult to hear. Thanks for that. It is a tough, you know, it's a hard to, if we have to mute the room because people want to be able to speak up whenever, but so it is helpful when people are able to be quiet during this, during the meetings. Okay. Caroline, I see your hand is raised.
It's Caroline. And I was thinking it'd be nice if we have time, maybe at our next agenda in June, to talk more about the different priorities that we want to focus on that we started today, but didn't get much farther than I think first two, the Medicaid waiver implementation, and began a conversation about eligibility and didn't make it farther than that.
Noted. Thank you. Laura.
Hi, everyone. Hopefully I will be able to be there in person for the next meeting, but I just wanted to say that I thought that this was very helpful. It was a great meeting. I'm looking forward to working with the MAC and not only, you know, bringing the oral health perspective, but CCO perspective as well. So thank you.
Thank you, Laura. Oh, and we have, yes, so Caroline is asking for a reminder for where we are next time. And where we are next time, thanks to Jerry in part, is in Corvallis, Albany.
Oh, nice.
Albany.
Oh, good.
This is why I write things down. Anyway, we'll be in Albany. Do you want to say something about the place where we'll be?
At the Albany Hospital. Yeah.
So
I've never been there, so fingers crossed it all works.
So very excited to get a little bit outside of where we usually are and maybe have an opportunity to bring folks in from the community that we wouldn't otherwise see. And we hope to encourage all of you, as many of you as is possible, to come down and join us. And I'm just going to note Shannon's comment that we may need to meet more frequently. I sure wish yeah, I sort of wish we could. And but yeah, there's a lot of merit to that idea. All right. If there, do you want to close us out, Heather?
Oh, I just thank you, all of you, for your vision and your commitment and your volunteerism and showing up and being so present and participatory. I really feel honored to be a co-chair and support you and support Oregon in the MAC work with such a great team, including our committee members and all of the staff. So thanks again for a good retreat. And yes, there will be more work to come on a tight schedule, but it'll keep us moving over the next year. So thanks for helping us launch it. Thanks so much, David, for guiding our journey today and getting us moving on our work plan for the next couple of years. Really, really appreciate you. You just are always so good at corralling us in such a nice way. So thank you.
My pleasure.
Thanks.
And I think we're adjourned.
We're adjourned.
We're adjourned. Great. All right.
Thank you. Have a good day.
Okay, there are lots of food.